Hi, good afternoon, viewers. Today, I want to discuss with you how can ultrasound help in optimizing fertility outcome. There are a lot of gray zones which I just wanted to clarify, but I will start with very basic. First, when we talk about infertility, what do we actually mean by infertility? By definition, it means failure to conceive after 1 year of unprotected intercourse. And as per the WHO statistics, the burden of infertility in Indian population is as high as up to 20%. Now, if you divide the total burden of infertility is one third contributed by the male, one third contributed by the female, and one third is unexplained. But if we take the female cohort, a population of just females, in that 35% is contributed by the tubal factor, 20% by the uterine or the endometrial factor, 20% contributed by the ovulatory dysfunction, and 25%, that means a quarter of, is still unexplained. We don't know the exact cause of it. Now, if you remember, folks, there was a time when it was an era of digital examination where if a woman walks into the clinic and complains of infertility or any gynecological symptoms, the clinician used to wear a gloves and used to do a per vaginal examination or the digital examination, and then they used to come to some logical differential diagnosis. It still can be done, but now in the era of ultrasound, and especially the transvaginal ultrasound, this is a much better, easier, and more informative option. And not only you can see on the monitor when you do a transvaginal ultrasound regarding the pelvic anatomy, but at the same time you can use your transducer in a dynamic way to look for so many more things, and you can do a functional assessment. So in the same sitting, you can do two things. Number one, you can do the morphological assessment by looking at the screen, and number two, by dynamic and interactive nature of the ultrasound, you can also do a functional assessment, like if she's getting pain at certain movements, or if there is any kind of pelvic adhesions where the organs will not be sliding freely. Now, coming on to the infertility aspect, if a woman comes to the clinic and you are supposed to do an infertility workup related to the ultrasound, it always starts with the baseline scan, which is done at day 2 or day 3. And we start with meticulous approach where we look at the uterus. We do a measurement of the uterus, which is called a quantitative or semi-quantitative assessment. We look at the endometrial lining, because most of the time they're supposed to be thin lining. And then we move on to the ovaries and adnexa. And once we are looking at the ovaries, we do take the ovarian volume, and at the same time we look at the antral follicle counts on both sides, and that gives us a very good idea about the functional ovarian reserve. So antral follicle count, what is this? This is basically if we add the follicles, number of follicles on the both sides, it gives us the summation of this will give us antral follicle count, which is reflective of ovarian reserve of that particular woman. The other way of estimating the ovarian reserve is doing a much more expensive test in the form of serum anti-Mullerian hormone or AMH. But instead of that, we can do it in the same setting and the baseline scan on ultrasound. And once we have done the baseline scan, then depending on the protocol, whether she is going for IUI or IVF, you call them back subsequently in the mid-cycle, where you again examine the uterus, and that time she will be in the late proliferative phase where you are expected to see a triple line endometrium. And once you see a triple line endometrium, in the same sitting you can do a 3D sweep to look into the morphology of the endometrium and rule out any potential Mullerian duct abnormality. And why is that important? Because if there is certain kind of Mullerian duct abnormality like septate or subseptate uterus or bicornuate uterus or didelphys, then it may need corrections for the better pregnancy outcome, because in the cases of especially septate and subseptate, they are more prone for miscarriage. So it's very important to understand that concept. And at the same time, we are also looking into the myometrium of the uterus in much more detail to look for any focal or diffuse pathology. When I say focal pathology, the most common focal pathology is in the form of fibroid. And not only documenting or measuring fibroid is important. The most important thing when we look at the fibroid is to do the fibroid mapping. And it's important because if those fibroids which is impinging on the endometrial cavity, they have negative effect on fertility outcome or the conception. So we have to very categorically measure, and at the same time, which is more important, mapping of the fibroid, which is called myoma mapping. And when we talk about the diffuse myometrial pathology, the most common is adenomyosis. So we look into adenomyosis, and then there are descriptors. I will not go into the technical aspect, but we report it and we describe it as it should be. Once these are done, then we move into the adnexa. And what is very important in adnexa is to look for first the ovaries and to rule out if there is polycystic ovaries. There are criteria to determine polycystic ovary because it is so very common in Indian population and it has got a detrimental effect on the fertility. So polycystic ovaries should be recognized. There are strict criteria because it should not be overcalled or undercalled. And at the same time, look at the tubes. Normally, in normal situation, tubes will not be visualized. It will be visualized only if it is distended with fluid, and we call it hydrosalpinx. So these things should be very clearly be seen and documented. And whenever there is any pathology, it's also important to look for the Doppler or the color flow in the vessel, because that gives us clue to certain differential diagnosis. And also when you're looking at the endometrium, try to look for any kind of intra-endometrial pathology like polyp or synechia. But here I would like to introduce all of you to a very novel and a very informative test in the form of saline infusion sonohysterography. In saline infusion sonohysterography, whenever we have doubt about any kind of intra-endometrial pathology, what we do is we put in little bit of normal saline via transcervical catheterization, which is done by a dedicated catheter meant for that purpose. And once we push saline into the endometrial cavity, entire endometrial cavity is distended with normal saline, and any pathology which is there in the endometrium, whether be it submucosal fibroid, polyp or synechia, gets very well delineated against the background of the fluid. So this is just like a virtual hysteroscopy, and it is less expensive, less invasive than hysteroscopy, and gives you almost an equal kind of information. Once we have done saline infusion sonohysterography, the other thing is to check on the tubal patency, because as I have told you, tubal factors contributes to 35% of the female infertility. So how do we check on the tubal patency? Because many times we come across a situation when after scanning, she asks that whether my tubes are open or not. Can we answer that question? Yes, we can answer, but it will not be possible to answer just on a normal transvaginal scan. For that, we have to push foam, which is done by the special catheter, by the transcervical catheterization. And once the catheter is inside the uterus, within the endometrium, after crossing the internal os, we inject a special foam, and this foam, as it passes across the ostia of the tube, it can be very well seen in real time on ultrasound as it passes across the tube. And if we trace that, we can see the spillage from the distal end of the tube very close to the ovaries. This is a very rewarding principle when we are looking at the infertility, because what we are doing is threefold. Number one, we do a baseline scan to understand the pelvic anatomy, to look for any structural abnormality, as I have discussed with you before. The second step is to push normal saline into the endometrial cavity by the process called saline infusion sonohysterography, SIS, to delineate any intraendometrial pathology like endometrial polyps or mucosal fibroids, synechia, and so on and so forth. And third step, last but not the least, is hysterosalpingo foam sonography, which is called HIFO-C. In this, we instill foam via the special catheter placed across the internal os by transcervical route, and we push foam through that catheter, and we can visualize that foam passing across the tube and spillage across the distal end of the tube. And once we see that, we understand that tubes are patent. And if we don't see spillage across one or both sides of the tube, then we wait for some time, because it may be pseudospasm, and again we gently push the foam to see if there is flow across the distal end of the tube. And still, if we don't find flow across the distal end of the tube, then we suspect that there may be tubal block on one or both sides, depending upon the scan findings. So this was all about the diagnostic. This was all about the diagnostic nature of ultrasound for the infertility assessment, but there is a therapeutic role as well. And this therapeutic role may be in the form of ovum pickup. When we do an IVF cycle, we give hormonal injections, and as the follicles grow and mature, which is done by follicle monitoring serially when we follow up, and then it needs to be retrieved. The oocytes needs to be retrieved, and the process of retrieval of oocytes from the matured follicle is called ovum pickup, which is done by a special ovum pickup needle in an OT setup under general anesthesia. So the same transvaginal probe can be utilized to do this process. And once you once you decide on the transfer of the embryo, ultrasound helps you to accurately place the embryo at the right place inside the endometrium by continuous guidance. So it also helps you in embryo transfer. Now, there should be a very good dialogue between endometrium and the follicle. As it is said, you need a good seed, and that seed should be sown in a good soil, fertile soil, to get the best result. And your seed is your matured follicle, and this matured follicle has got several parameters based on grayscale and color Doppler, which helps us to ascertain whether it is a good matured follicle or not. And once we determine that, the next step is to look for the endometrial receptivity, and that also can be determined on grayscale and on color Doppler. And once we are sure that yes, this endometrium is a good receptive endometrium, that is the time when we plan for transfer of that embryo for the best possible results as far as implantation is concerned.